Good evening, everybody. Welcome to this evening episode of Pursue, and this is Pursue 8E, and we are streaming live from AIIMS Bhubaneswar via Kolkata. And today's topic is very interesting, plasma cell dyscrasias, and to talk on that, we have Dr. Suvradeep Mitra, who's an MD from PGI Chandigarh, DM in Histopathology from PGI Chandigarh, a PDCC and ICP in Renal and Transplant Pathology from PGI Chandigarh. Presently is an assistant professor in the Department of Pathology and Lab Medicine, AIIMS Bhubaneswar, with more than 70 publications in indexed national and international journals and 2 book chapters. An expert in renal pathology, a very well-known person in renal pathology. Let me request, before I request Dr. Suvradeep to start, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Suvradeep Mitra, sir, please share your screen and start. Thank you.
Thank you, sir, for such a kind introduction. And
your sound is a bit not very clear.
Okay. Am I audible better, sir?
Yeah. Now it's clear.
Okay. Right. Okay. A very happy New Year to everyone. I will start now sharing my screen. Right.
Yeah, we can see your screen. Yeah.
Right. Yes. So I think we are done. Okay. Thank you, sir. This class has actually been postponed because I fall sick suddenly. So today we'll discuss on renal diseases associated with plasma cell dyscrasia. So in recent times, before I start, I will just, there are some disclaimers. I'm sincerely thankful to my mentor, Professor Dr. Nada in PGIMER Chandigarh, to my PGI alumnus who have taught me a lot. Obviously, Nadeem sir, who have given me this opportunity and who has also helped me postponing this class on a very short notice. I currently work in AIIMS Bhubaneswar, and I am really grateful to all my faculty members, my residents and the technicians, and especially to my nephrologist Dr. Sandeep Panda and my colleague Dr. Suvendu, who also helped me in carrying on nephropathology.
Right. Your voice is getting away very quickly. I mean,
okay.
Just have to be a bit careful with that.
Yeah. Just hold on, sir. Just hold on.
Yeah. Take your time. No problem.
Right. Sir, is it better now?
Hello?
No.
No, not at all.
Okay.
The previous thing was much better, but it was coming and going.
Okay. Okay. Is it right?
Yeah, it's. Can you speak a bit louder then?
Okay, sir. Is it all right?
Yeah, no, it's fine. Yeah.
Right. So, plasma cell dyscrasia is basically a hematological topic, and if you have gone through the WHO Hemat in recent times, it has significantly modified the classification of plasma cell dyscrasia has really been modified from what we had seen in previous WHO classification. But when we talk of renal involvement in plasma cell dyscrasia, we have to remember that there is, if you read the classification of plasma cell myeloma, you will find that there is something called CRAB, where the R stands for renal involvement. So basically, we call it myeloma when there is CRAB. I mean, out of different other organ system involved, renal is also one of them. But it has been noticed that you do not really need a myeloma diagnostically in a patient for renal involvement to occur by a monoclonal disease. So there is a concept of monoclonal gammopathy of undetermined significance in hematology, which means the CRAB criteria are not fulfilled, but the uh, the clonal plasma cell, which is less than 10%, and the M protein, which is less than 30 gram per liter. So that is MGUS. But if we go through the spectrum of plasma cell dyscrasia, according to the hematological classification, it is only in plasma cell myeloma when there is involvement of the kidneys. But when we practically see the renal biopsies, we have seen that even without diagnosis of any myeloma or a B cell neoplasm, we can have renal involvement by monoclonal diseases. So this is the impetus for a nomenclature known as MGRS, or monoclonal gammopathy of renal significance. So before we go deep into discussion of this particular topic, we first have to understand what is MGRS, or monoclonal gammopathy of renal significance. This terminology was coined by International Kidney and Monoclonal Gammopathy Research Group in 2012 and has been further modified in 2018-19. So they have defined it as clonal proliferative disorder, any B cell or plasma cell that produces a nephrotoxic monoclonal immunoglobulin and does not meet previously defined hematological criteria for treatment of a specific malignancy. So what does it mean? It means there has to be a clonal proliferation of any B cell or plasma cell lineage, and that particular clone will produce a monoclonal immunoglobulin which has nephrotoxic property. However, the catch is, for monoclonal gammopathy of renal significance to occur, this particular clone does not always need to be a malignant clone. Sometimes it is so subtle that you even cannot detect it hematologically. And this particular clone, according to the hematological definition, does not require a treatment for malignancy. So you do not always need it to be a malignant clone. There should not be always satisfaction of a particular definition for MGUS or myeloma or something of that sort, but even a very subtle monoclonal clone can produce monoclonal gammopathy of renal significance, and there are a whole lot of diseases which come under it. So the first of all, the corollary of this particular definition is, by definition, MGUS should not have any end organ damage. However, in MGRS, renal involvement can still occur without a malignant clone. So here also, this particular group also have defined the terminology known as dysproteinemia, which is basically this clone which is characterized by overproduction of an immunoglobulin in its entirety or a fraction of it by clonal expansion of cells from the B cell lineage or plasma cell lineage. So when we talk of renal involvement by plasma cell dyscrasia, we do not only talk of renal involvement in a diagnosed case of myeloma or Waldenstrom macroglobulinemia or smoldering myeloma or any other disease, any other B cell NHL for that matter. but we also talk of the typical lesions which can only occur after a monoclonal injury, but there is no hematological um, myeloma in that particular patient. So, MGRS associated diseases can be divided into monoclonal immunoglobulin deposits or no monoclonal immunoglobulin deposits. Out of monoclonal immunoglobulin deposits, they can be organized deposits, they can be non-organized deposits. So obviously you can understand that when we talk of organized deposit and non-organized deposits, we have to do ultrastructural study, we have to do electron microscopy, without which in light microscopy and direct immunofluorescence, you cannot really call something as organized deposit or not organized deposits. These organized deposits can be dominantly of three types. One is fibrillar, one is microtubular, and another is crystalline. So we'll come to this. And non-organized deposits can be monoclonal immunoglobulin deposition disease or MIDD, proliferative glomerulonephritis with monoclonal immunoglobulin deposition or PGIMER, and there is a miscellaneous group. So out of fibrillar, if we look at the electron microscopy of amyloid, we will find that they are fibrils. They do not have, the thickness is 7 to 12 nanometer approximately, and the thickness is not much, and there will be randomly arranged fibrils in the ultrastructural study. So immunoglobulin related amyloid is an example of fibrillar kind of deposit. Also, the fibrillary glomerulonephritis, which is monoclonal, is also an example of fibrillar kind of deposit. Out of microtubular deposit, the microtubules are usually has a larger diameter than these fibrils. Usually the diameter is something between 30 to 50 nanometer. So these are larger in diameter and also usually has a central empty area. And immunotactoid glomerulonephritis or cryoglobulinic glomerulonephritis of monoclonal etiology are the typical examples of microtubular kind of deposits. Light chain proximal tubulopathy, especially crystalline variant, crystal storing histiocytosis and crystal globulin histiocytosis are the, sorry, this is wrong, crystal globulin glomerulonephritis are the examples of crystalline kind of deposits. Next, in these patients also thrombotic microangiopathy can occur, and C3 glomerulopathy associated monoclonal gammopathy can also occur, and these are the examples of not monoclonal immunoglobulin deposits. So this is a very overall classification of diseases which are associated with monoclonal gammopathy of renal significance. This is a wholesome chart just to highlight that what are the renal lesions associated with monoclonal gammopathy. In addition to what I have already discussed, you can see that there is light chain cast nephropathy, both crystalline and non-crystalline variant. Now please look at the proportion of lesions associated with multiple myeloma. Light chain cast nephropathy is considered to be a myeloma defining disease. So if you have light chain cast nephropathy, majority of the cases ultimately will be diagnosed as multiple myeloma. But there are a few cases of Waldenstrom which can show you light chain cast nephropathy, yes. But if you look at amyloidosis or MIDD or proximal tubulopathy and association with myeloma, you just see that only 1/5 or 1/3 of cases of these diseases will be associated with myeloma, because these are the diseases which ultimately these patients never ultimately develop myeloma. That can be a consideration, or they can have other B cell NHL. So this here begins the concept of monoclonal gammopathy of renal significance. When we talk of these diseases, also these are the mechanisms by which you can classify these diseases. amyloid or immunotactoid or fibrillary proteins or MIDD. These are basically, these occurs via deposition of this monoclonal immunoglobulin. In contrast, in case of cryoglobulinemia or cryocrystalloglobulin, CSN, this kind of diseases, it's usually the precipitation or crystallization of the cryoprotein or the monoclonal protein that perpetuates the disease. POEM syndrome or C3 glomerulopathy associated disease or thrombotic microangiopathy, obviously these are not related to any deposition or precipitation of monoclonal immunoglobulins, but an uncontrolled complement and cytokine activation is the basic pathogenesis of this kind of diseases. And this is basically how to approach these diseases. Especially you see that what are the indications of biopsy in a patient who are suspected of monoclonal gammopathy. Once kidney biopsy is done, we have to do light microscopy, we have to do direct immunofluorescence, especially the kappa, to look at the kappa and lambda chain restriction, and obviously electron microscopy. In majority of the cases, electron microscopy is a mandate because we cannot diagnose many of these cases confidently without electron microscopy. And obviously there are other investigations other than routine direct immunofluorescence. We may have to do IgG subclass, and ultimately in cases of amyloid deposition, you may have to do mass spectrometry to identify the type of protein, etc. But this is a general flow chart to identify these renal lesions. With this background, I will now discuss the histomorphology of these cases, the direct immunofluorescence and electron microscopy of cases. I have prepared these cases keeping in mind the postgraduate students, so that they are maximally benefited by this case. And I have purposefully omitted the cases which are rare or uncommon or do not really asked in postgraduate exams. So now we are talking of a 60-year male who had presented with rapidly progressive renal failure, and this person has a history of low backache for last 6 months. So this kind of history is very much suggestive of maybe a plasma cell or a clonal disorder. The patient is obviously non-hypertensive and non-diabetic, and as you can see that there is rapidly progressive renal failure. The serum creatinine has shot up to 6.2 grams per dl, and the patient is suffering from oliguria. And this is the kind of condition when the clinicians actually call you up and ask you to generate a report as fast as possible. So when we looked at the biopsy, you can see these are the glomerular compartment. The tubules are really dilated, and there is simplification of the tubular epithelial cells. And here you can see that there are some casts inside the tubule which are fractured in nature. This is the PA stain, and as you can see that these particular casts are not taking up the PA stain. This is faintly PAs positive, and the glomeruli appear to be normal, and there is some degree of acute tubular injury which is going on. Let's see. So you can see that these are the kind of casts that we can see, and they are absolutely PS negative. Just for comparison, the tubular basement membrane, which is a PS positive structure, and you can see these casts are PS negative, and you can see that they are angulated, there are geometric shapes, and they are fractured at places. Also, as you can appreciate that there are some giant cell reaction here and there around these casts. This is just to highlight the Masson trichrome stain. Sometimes you can see a little bit of polychromatophilia in Masson trichrome stain in this fractured casts. So with this, our first impression was there is intratubular PS negative casts with giant cell reaction. Obviously, when we look at such kind of PS negative fractured and geometric angulated kind of cast, the first differential that come in our mind is a light chain cast nephropathy. But with light microscopy only, we really cannot confirm the diagnosis. So we can just raise the possibility that whether it could be light chain cast nephropathy or not. We also looked into the tubules, and as you can see that some of the tubules, you can see here, the nuclei are not present in the proximal tubules, and instead the tubular epithelial cells contain a lot of deeply eosinophilic globules, and the glomeruli appear to be normal. There is no amyloid deposit, and there is no other deposit in the glomeruli. Now, when we did light microscopy, as you can see, these are the same areas, and this is the kappa uh, direct immunofluorescence. Look at the intensity, compare the intensity between kappa and lambda, and obviously lambda intensity is at least by at least 2 plus. If it is 3 plus intensity, we call it as 1 plus intensity. So there is definite lambda restriction in the cast. So when we see such kind of restrictions in the casts, we call it a light chain restricted or light chain cast nephropathy, and in this particular case it is lambda restricted. Also, in the tubules, as you have seen the globular kind of deposit with changes of acute tubular injury, similarly, you can see that lambda is also restricted in this intratubular uh, droplets. So these changes are known as light chain proximal tubulopathy. So there is a combination of light chain cast nephropathy and light chain proximal tubulopathy in this particular case, and it is lambda restricted. This is just to show you another case. You can again see this kind of very much fractured and angulated cast. This is also a case of light chain cast nephropathy, but in contrast to the previous one, you can see much more degree of crystallization. They are absolutely geometric shaped, and some of the tubules, tubular epithelial cells, also contain this crystallized kind of material. And when you see such crystallized material inside the proximal tubules as well, usually it is associated with kappa restricted or crystalline proximal tubulopathy. Right. So when we talk of these light chains, because it is the free light chains which are excreted through urine, they are the major nephrotoxic material. So when we talk of MGRS or monoclonal gammopathy of renal significance, the basic pathogenesis of MGRS lies in the free light chain excretion. And these free light chains, depending upon their own structures, can be tubulopathic or glomerulopathic. While majority of the free light chains are tubulopathic, uh, at least one third of these free light chains are glomerulotoxic or glomerulopathic as well. So just to highlight how this free light chains cause tubular injury and form the casts, these particular free light chains are usually endocytosed by the proximal tubular epithelial cells, by the megalin-cubulin complex. Then they are engulfed, go to the lysosomal compartment via the endosomal compartment, and these free light chains can generate a lot of free radical injury in this proximal tubular epithelial cells, by means of which the proximal tubular epithelial cells gradually degenerate. Also, this formation of free radical, especially hydrogen peroxide, elicit the transcription of numerous pro-inflammatory and pro-fibrotic kind of interleukins, especially interleukin 6, interleukin 8, and macrophage chemoattractant protein. And that's why there are a lot of macrophages, because I just told you that there are giant cells around this fractured cast, and that's the reason for the giant cells to come. They are actually macrophages, there is release of a lot of macrophage, chemoattractant protein which come into play. And so these free light chains cause injury to the tubular epithelial cells and also start getting deposited inside the uh, proximal tubule. And this is the hydrogen peroxide mediated injury which occurs in the tubular epithelial cells and the generation of this pro-inflammatory and pro-fibrotic cytokines. Furthermore, these free light chains also get attached to uromodulin, and this is the major gel forming substrate for these free light chains. This and TAM phosphol protein further help in the formation of these uh, light chain casts. Obviously, the light chain casts are more produced in distal convoluted tubule and collecting duct, but obviously the proximal tubule is the area where the nidus starts forming. Naturally, dehydration or diuretics or radio contrast or a change in pH inside the tubular fluid obviously promote the nidus formation and formation of light chain cast. As I have already discussed, that light chain cast nephropathy is often a nephrologic emergency, and often the clinicians ring up to give you a provisional report at least. So light chain cast nephropathy is a myeloma defining illness. Usually it is lambda light chain which is restricted, but when you find crystalline, uh, especially crystalline proximal tubulopathy, uh, you may suspect kappa light chain restriction. These light chains are resistant to urinary and macrophage metalloproteases, and that's why they keep on accumulating. Uh, the plasmapheresis and chemotherapy directed to the myeloma clone is the best treatment possible, although there are different other treatments which can be, depending on patients, be beneficial for these patients. Talking of light chain proximal tubulopathy, they can be crystalline or non-crystalline. It's basically the acute tubular injury that occurs because of free light chain. The non-crystalline variant is lambda light chain restricted usually, and crystalline one is usually kappa restricted. The crystalline type of light chain proximal tubulopathy presents with Fanconi syndrome. Means there would be amino aciduria, there would be glucoseuria, and there would be phosphaturia and many other things, whereas non-crystalline proximal tubulopathy usually comes up with renal failure or renal dysfunction. Obviously, in both kinds of tubulopathy, the features are of acute tubular injury and basolateral deposition of light chains with interstitial inflammation. Uh, I just showed you a photo of lysosomal of large eosinophilic globules inside the tubular epithelial cells, and those are basically because of free light chains which are ingested but could not be digested by lysosomes, and this is called as lysosomal indigestion, constipation kind of scenario. The other thing which can occur by these light chains are monoclonal light chain mediated tubulointerstitial nephritis. Obviously, the light chains here are deposited along the tubular basement membrane, and inflammatory cells are elicited, and inflammatory reaction is elicited, which come to engulf this light chain, and it elicits an acute tubulointerstitial nephritis in response to the deposition of monoclonal light chains. So I'll move on to the next case now. So this is a 70-year male who had presented with renal dysfunction. There is no history of lymphoma or plasma cell dyscrasia in this patient. Again, he was non-diabetic and non-hypertensive, and also in addition to renal dysfunction, there was subnephrotic range of proteinuria. So this is the biopsy. This is the PA stain. As you can see that the glomeruli are quite enlarged, and you can see that there is lobular accentuation. Uh, Also, you can see that there are multiple nodules which have formed uh, globally in the glomeruli, and the nodules are quite symmetrical, quite cellular in its appearance. These are the nodules. As you can see, they are quite symmetrical and very cellular at places, and obviously, as you can see, that they are PAS positive. Also, just I wanted to highlight that the tubules also have quite thickened tubular basement membrane. So this kind of feature in a 70-year male can occur because of several reasons. So this pattern is known as a nodular glomerulosclerosis pattern. The most common causes for this nodular pattern would be diabetic nephropathy, amyloidosis, and monoclonal immunoglobulin deposition disease. Obviously, diabetic nephropathy is the commonest, and sometimes even when the clinician says that the patient is non-diabetic and we think that still diabetes could be ruled out, we often raise the possibility that please rule out a diabetes mellitus, and because that is the most common cause of this nodular glomerulosclerosis pattern. Many other diseases, including immunotactoid and fibrillary GN, collagenofibrotic and fibronectin glomerulopathy, idiopathic nodular glomerulonephritis, and MPGN, can show nodular glomerulosclerosis pattern. I will now try to try to tell you how to distinguish between at least these three major entities, and morphologically how far you can go to say whether this is because of diabetes, this is because of amyloidosis, or this is because of MIDD. So if you look at the type of nodule, in MIDD, the nodules are symmetric and cellular, whereas in diabetes, it is usually asymmetric and acellular nodules. In amyloidosis also, the nodules are usually asymmetric and acellular. I will show you the cases also. So, in diabetes, usually the nodules are capped by a peripheral patent loop of capillaries, also known as pseudoaneurysmal dilatation of capillaries, which is absent in cases of MIDD and amyloidosis. The glomerular basement membrane will be thickened in both diabetes and MIDD. However, peculiarly in amyloidosis, it may be preserved or it may be kind of destroyed in cases of amyloidosis, but not thickened. One typical property of diabetes are the exudative lesions in the form of capsular drop or hyaline cap, which can be seen in diabetes and are usually absent in MIDD. If you look at the tinctorial character of the nodules, the amyloid will show you pale eosinophilia in HNE, whereas both diabetic nodules and MIDD nodules will be deeply eosinophilic. One important clue of Another important clue is looking at the tubular basement membrane, interstitium, and the vessels. In cases of diabetes and MIDD, both the TBM can be thickened, and in amyloid, it may be or may not be thickened. Vascular hyalinosis can be seen in diabetes or MIDD. In amyloid, similar kind of amorphous material can be deposited, which is pale eosinophilic. That kind of material can be deposited. And usually in diabetes, the interstitium shows a lot of fibrotic changes, tubular atrophy, inflammation, etc. In MIDD also again this kind of changes can be seen, but also similar kind of deposition can be seen. When you do spatial stains, the diabetic nodules and the MIDD nodules are PAS positive, whereas amyloid nodules are PAS negative to weakly positive. The diabetic nodules are usually silver positive. MIDD nodules are usually positive, sometimes can be negative, but in amyloid it is usually almost always negative for silver stain. One excellent stain for demonstration of amyloid, as you all know, is congruent stain. Obviously, direct immunofluorescence is one of the best methods to document this monoclonal immunoglobulin in MIDD as well as in immunoglobulin restricted amyloid. Obviously, in case of immunoglobulin restricted amyloid, this other immunohistochemistry will be negative. Ultimately, the electron microscopy is out of help because in diabetic glomerulosclerosis, although there can be some cases where fibrillary degeneration can be seen, which is known as diabetic fibrillosis, the typical ultrastructural feature of diabetes is the loss of the trilaminar membrane of glomerular basement membrane. For MIDD, there are powdery deposits which are amorphous, and for amyloidosis, there are haphazard non-branching kind of fibrils. I'll show you the pictures for better appreciation now. So just have a look at the MIDD nodules just before we go to the diabetic nodules. They are very symmetrical, very cellular, and you cannot really see a peripheral patent loop of capillaries. Now I'll show you the diabetic nodules. So these are the HE and PAS and Mason and Jones figures. Can you see that they are very asymmetrical? So this area there is a nodule, rest of the glomerular tufts do not have a nodule. These nodules have a peripheral patent loop of capillary. They are asymmetric, they are not quite cellular, and they are methenamine silver positive. Just to highlight the nodules once again, you can see pseudoaneurysmal dilatation of capillaries capping these kind of diabetic nodules, right? Very hypocellular, really acellular kind of nodule and asymmetric unlike the MIDD nodules. Also you can see that these are the kind of institutive features which I was talking about. These are the capsular drop. This is the hyaline cap and this is the capsular drop. Nicely highlighted in Jones, they are Jones negative. So these are the additional or supporting features of a diabetic nodules. Also, you can see that the tubular basement membrane can be thickened just like MIDD in diabetes mellitus as well. When you do immunoglobulin, the direct immunofluorescence, you cannot document light chain restriction in diabetes mellitus, right? Which means that if you compare the intensity of kappa and lambda, one intensity would be at least 2 plus more than the other intensity. So you cannot document light chain restriction in cases of diabetes mellitus. What you see is known as pseudo-linear accentuation. It's just like a pencil kind of accentuation, and when you have a doubt, you do an albumin stain, and albumin non-specifically is trapped in these glomerular capillaries, and that's why albumin also gives such kind of positivity in diabetes mellitus, which is never the case in any other MIDD or amyloid. When you do electron microscopy, so you see that when you look at this glomerular basement membrane, there is no trilaminar structure. When you see a normal glomerular basement membrane, you see lamina rara and lamina densa. Lamina densa being sandwiched in between two lamina rara. But here you see that there is loss of this trilaminar structure. This is a photograph from one of the major articles, just to highlight that what kind of changes you see in different, what kind of ultrastructural changes you see in different forms of MGRS associated diseases, just to highlight that these are the kind of fibrils, the fibrillary kind of appearance that we see in amyloidosis. Whereas when we talk of microtubule, you see that this kind of fibrils, they are much thicker, and when you closely look, there is a hollow or an empty space in between these tubules. They are curvilinear in cryoglobulinemia. They are in immunotactoid, however, they are fibrillar. In cases of crystal storing diseases or crystalline diseases, these are the kind of crystal formation which can occur inside the tubular epithelium, which can occur inside the histiocytes in crystal storing histiocytosis, etc. Whereas if you look at this tiny, very powdery black kind of deposit, amorphous deposit, that's the typical feature of MIDD. And in PG and MID or proliferative diseases, you see deposits just like any other immune complex type deposits. So just to tell you the differences between different uh, ultrastructural features of MGRS associated lesions. So as I was discussing about the nodules of the second case, when we did kappa and lambda light chain, you see that there is significant degree of kappa light chain restriction which is linear around the tubular basement membrane, whereas lambda is nearly negative. So there is kappa light chain restriction in this particular case, and so we could label it safely as monoclonal immunoglobulin deposition disease. Obviously our finding was supported by the electron microscopic feature. You can see this kind of nice powdery deposits along the tubular basement membrane which occurs in MIDD. So in both MIDD as well as in amyloidosis, there will be formation of glomerular nodule, which is known as nodular glomerulosclerosis pattern. And when we look into this pathology of why in amyloidosis the nodules are acellular and why they are very cellular and symmetric in cases of MIDD, we see that there is a differential expression of TGF beta and PDGF beta in amyloidosis and in MIDD, especially both TGF beta and PDGF beta are released at a much higher quantity in cases of MIDD, and TGF beta brings about the proliferation, the cellular proliferation, and the PDGF beta brings about the matrix expansion in cases of MIDD. Also, very importantly, the matrix metalloprotease is not really active in cases of MIDD, which helps in the expansion of the nodules. Whereas the matrix metalloprotease is very much active in amyloidosis, and therefore it actually eats up the matrix and helps in the deposition of the amyloid material. This is, if you want to go in detail of the pathogenesis, I have given the reference because it will be too much to discuss this. The processing of MIDD proteins and amyloid proteins, there is differential processing. Also, there is differential kind of phenotypic expression by the messenger cells. Also, you can always refer to this article for understanding this pathogenesis. So the final diagnosis, our case 2, was monoclonal immunoglobulin deposition disease. It was light chain deposition disease actually, because immunoglobulin G, A and M were negative in that particular case, which I have not shown, and it was kappa restricted. So this brings us to our third case. Again a 50-year male, but here this patient presented with nephrotic syndrome, heavy proteinuria actually. There is only a mild increase in serum creatinine. There was no history of TB or chronic infection or multiple chronic infection, but the patient is a known case of multiple myeloma. Again, non-diabetic and non-hypertensive patient, and the ultrasonography revealed abdominal visceromegaly. This is a very, very typical feature of amyloid deposition otherwise. So when we looked at the hematoxylin and eosin stain, as you can see, again formation of nodule, they are not really symmetrical and definitely acellular. Unlike the previous cases, the eosinophilia is really pale in this particular case, right? Again, very pale eosinophilia, and as you can appreciate that the same kind of material is also deposited in the arteriole, which is afferent afferent or efferent arteriole, right? Also, please note that the glomerular basement membrane is not really uniformly thickened, so there is deposition of this kind of paleosinophilic amorphous hyaline kind of material, which is PAS negative. As you can, if you can remember the PAS positivity in cases of MIDD and diabetes mellitus, and you see that they are very much PAS negative. Also, if you look at the basement membrane, they are not really thickened, but at places the basement membrane is gradually kind of getting destroyed by the encroachment of the material from the mesangial area. This is a typical appearance, is known as coxcomb appearance. I'm not going into detail of this. So again, nodular glomerulosclerosis pattern, and obviously these are our first three differentials, and obviously we did a congruent stain on a thick section with an external control, and this is known as congophilia, right? Proximal convoluted tubular epithelial cells are also Congo positive because of huge content of mitochondria. And as you can see, this is nicely showing apple green birefringence under polarizing microscopy. You can also see that similar kind of congophilic material is deposited in and around the vessels and also in the interstitium in this particular case, right? And that also shows beautiful apple green birefringence. Obviously, there was lambda chain restriction in this particular case, and you can see that the deposits are dominantly mesangial. Also, they are encroaching upon to the basement membrane, and this is known. This is not a granular or linear kind of deposit, but rather we call it a smudgy kind of deposit. We obviously performed ASAA immunohistochemistry, which is for the secondary amyloid or inflammation associated amyloid, and SAA is negative. This is just to show you the nodular glomerulosclerosis pattern under toluidine blue. This is a semi-thin kind of section, and you can see the material, similar kind of material deposited. Obviously, we did the electron microscopy, and you can see this kind of fibrillar structures which are very, very random, very, very haphazardly arranged. And if you measure the size would be approximately 8 to 12 nanomicron. And these are the kind of fibrils which are very, very randomly and haphazardly arranged, and they are non-branching. They are constantly growing, but they have no branches. They are kind of crisscrossing with each other. So with this, the ultimate diagnosis in this particular case, the amyloidosis, lambda restricted type, a L type of amyloid. There are many other types of amyloid other than the immunoglobulin associated, and that's a completely separate topic for discussion. So these are the three very important diseases which are often asked in the postgraduate exams, and these are very, very important for the postgraduate trainees, especially in context to plasma cell dyscrasia associated renal lesions. First of them is obviously light chain cast nephropathy. Second is obviously amyloidosis, and the third is monoclonal immunoglobulin deposition diseases. Amyloidosis, MIDD, and diabetic glomerulosclerosis come in the differential because of their nodular glomerulosclerosis pattern. I have given you a comprehensive chart to distinguish between these three common causes of nodular glomerulosclerosis pattern. Usually, the amyloidosis patients present with heavy proteinuria along with some degree of renal dysfunction, whereas light chain cast nephropathy patient usually presents with acute renal failure or rapidly progressive renal failure or a very high rise in serum creatinine. Proteinuria is usually not the case of light chain cast nephropathy. MIDD patients usually present with a combo of subnephrotic kind of proteinuria and some degree of rise in serum creatinine, a combination of both. And I have given you the morphological clues as well as direct immunofluorescence and electron microscopic features by which these three patterns of nodular glomerulosclerosis can be distinguished. Before finishing, I just want to discuss a few other interesting cases which I have come across in my reporting, but I don't think you will see it often, and they are not really important from postgraduate point of view. So this was one case which I saw in PGI under the supervision of Dr. Ritambra. This was actually an autopsy case of a 40-year male myeloma patient, and when we looked at the tubules, they were really distended by this kind of cast. In contrast to the fracture, geometric, and angulated kind of casts, which of light chain cast nephropathy, which I already have shown you, these casts were not really PS negative, and they have a typical arrangement. And you can see that there is a radial kind of arrangement. The central area is oval, from which there emanates this kind of spicules. And when we did a Congo rate, these casts were congophilic with apple green birefringence. This is an extremely uncommon entity which is associated with myeloma. Obviously, there was lambda light chain restriction in this case as well, and this is known as amyloidogenic cast nephropathy. Please do not remember these entities from postgraduate exam point of view, but know that there are such kind of uncommon entities as well. This is another case, just to show you the morphology. If you look at the glomerulus, there is significant degree of mesangial matrix expansion. There is obviously glomerular basement membrane thickening, and this is the PA stain, so obviously this is PAS positive. And besides this matrix expansion, you can also see mesangial hypercellularity at places, and at places you can also note such endocapillary hypercellularity. So there is a proliferative kind of pattern here, and when we did immunoglobulin staining and kappa lambda staining, although there is a kappa restriction in this particular case, there is granular deposit of immunoglobulin G and C3, especially in the mesangium as well as in the basement membrane. So we were at a fix that there is obviously a monoclonality when in terms of kappa and lambda light chain is concerned, but this kind of there is a proliferative pattern and granular deposit. When we did electron microscopy, you can find that there are subendothelial, just like immune complex kind of deposits, which are very odd for any MIDD or amyloid. So this is an entity which has gained a lot of acceptance in recent years, which is known as proliferative glomerulonephritis with monoclonal immunoglobulin deposits. So before I finish this class, let me tell you that this is a huge topic. The usual postgraduate question about this topic is a long question about enumeration of the renal changes in plasma cell dyscrasia. Other than the chart which I have already given to you, please mention infiltration also as a component of these changes. So other than whatever I have already shown you, this kind of deposits which can be or which are monoclonal immunoglobulin deposits or no monoclonal immunoglobulin deposits, organized, not organized, etc. Please add to the list infiltration by myeloma or infiltration by a B cell NHL, which is also pattern. In case of myeloma, it's not very common, but in cases of NHL, it can be seen. Please remember that not only myeloma, but also smoldering myeloma, but also B cell NHLs like CLL, they can, importantly, Waldenstrom macroglobulinemia can involve the kidneys. You do not really require a malignant clone to be hematologically defined for the diagnosis of monoclonal gammopathy in kidney, because we have seen that majority of the times, irrespective of a malignant clone, even a very subtle clone, a hematologically very subtle clone, can secrete lot of nephrotoxic monoclonal immunoglobulins, which can deposit in the kidneys and cause a disease. And that there brings the concept of monoclonal gammopathy of renal significance, which I have already discussed. And the three major exam slides which can be given from this topic is obviously amyloidosis, MIDD, which is in differential with diabetic nephropathy, KW lesion especially, and light chain cast nephropathy. These are the three most important exam based slides which can come up from this particular topic. And there are many entities, this is constantly growing, many rare entities are also upcoming, which I have just given you a little bit of clues of. With this, I say Happy New Year to all of you and thank you.
Thank you, Dr. Suvradeep. Wonderful lecture, excellently presented, and absolutely keeping in mind what is relevant. There is no end to this, and it's a very confusing topic with so many other entities coming every day. I think you have limited to what the postgraduates and the FRC path entrants would require.
Yes.
And the best part of it is the case-based teaching was so interesting and so
Thank you,
relevant.
sir.
And thank you so much. God bless you. There
Thank
are
you,
no
sir.
questions yet. Let's just wait for a minute. Let me see if there are any questions on the YouTube, and then we can conclude. No, there are no questions on the YouTube either. Thank you so much. Right. God bless you.
Thank you,
Take care.
sir.
Bye bye. Good night.
Thank you,
Take
sir.
care.
Bye
Bye
bye.
bye.
Good night, sir.
Bye.
Bye.
Good night.
Bye, sir. Thank you.